Good afternoon, everyone. My name is Stephanie Quillen, and I will be the moderator on today's webinar. Today we'll be covering the webinar, Implementing Key Integration Principles, with our presenter, Jeff Capobianco. Before we get started, I'd like to draw your attention to some important webinar logistics. Today's webinar is being recorded. An audio version of the entire webinar and a PDF of the presentation will be sent to you via email within 48 hours of the webinar. You are currently in listen-only mode. If you are listening on your phone, please enter the audio pin from the control panel on the right of your screen onto your phone's keypad. You may send us questions for the speakers at any time during the webinar. Simply type your question into the dialog box to the right of your screen and send it to the organizer. Depending on the question, I may type back an answer to you, interrupt the speaker and answer it, or save it to the end. We will answer as many questions as time allows. If you experience technical difficulties at any point during the webinar, please call Citrix Tech Support at 888-259-8414. Now I will turn the presentation over to Joan King to introduce Jeff.
Hi, everyone, and I know Stephanie said good afternoon. That's because all of us are on the East Coast and it is afternoon, but for all of you it's still morning, so good morning on this Friday before Memorial Day weekend, and thank you all for making the time to join us for the first in a series of webinars for the folks in Montana. And I'm Joan King, and I've met many of you as I'm looking at who's on the webinar, and I'm delighted that we have this venue of webinar so that I can introduce you to a variety of my colleagues in the coming months. This morning, I'm particularly happy to introduce you to Jeff Capobianco, who is a wonderful colleague of mine who brings a wealth of knowledge and experience to this topic. Jeff works as the Director for Quality Improvement in the Center for Integrated Health Solutions and works with me in the National Council Consulting Group as another integration consultant. So I'm really looking forward to hearing what Jeff is going to bring to us. I learn something every time I listen to Jeff talk. So Jeff, thanks for joining us, and I'll turn it over to you.
Well, it's very nice of you, and welcome everyone. Welcome to your Friday before the holiday weekend. No better time than to be talking about what we're going to be talking about today. I'm looking at the attendance list. I do recognize some names. I do recognize that some people are not attentive, which means you're doing email, which is your choice. But I'm going to be talking about some pretty intense items as it relates to integrated care. So we'll need your attention on this, or you're going to get lost, because not only am I going to speak quickly, but I'm assuming that you all, having had exposure to Joan and her great work, and a little bit from me, because I've been out to Montana once, that you've got a pretty good understanding of integration. As you can see in the presentation overview, I am going to discuss some basic components of integration, some terms, and then I'm going to dive deeper into care coordination, the development of care pathways, team-based care, workforce readiness, what do your staff need to be thinking about, knowing how to do, and then factors influencing organizational change as your organization looks to do the fun and difficult work of integrated health, which is a systems change. And then we'll have time at the end for discussion. Anytime you have questions as we move through this, please be typing those into the chat box to your right, and we will take them as they come. Stephanie and Joan can stop me as I'm moving forward in my presentation. Next slide. So as you're all well aware, we're 6 years on from the Affordable Care Act. It feels like it was yesterday. There are so many different terms that are being used in healthcare. Each state, each provider, each clinician has a little different understanding of what these terms mean, and that's a problematic if you're going to create systems change within your organization. Next slide. As you'll hear me move through the organization, I'm going to do my very best to define terms, because terms are the things we use to design our thinking, design our beliefs, and ultimately the use of terms like integration, care coordination, population health management, confidentiality. The way we define these terms in the context of our work every day drives our behaviors. So as a leader of an organization, as a clinician working with a client, if you're not clear on what you're talking about, what your terms mean, it's going to be hard for you to convey those in a reliable way to the person you're working with, and their behaviors aren't going to line up with what you would like to see them do. So if you're the leader of an organization, you really have to be clear as to what you mean about integrated health, what you mean about care coordination, what do you mean about now we have to start screening for physical health. Defining those terms is really important. Unfortunately, we have a lot of these terms being used in the healthcare arena, and policymakers, clinicians, administrators haven't spent the time to really spend the time to define them with each other sometimes, which it just adds to confusion. Next slide. So even with the term integrated health, we find that that term gets defined differently depending on who you talk to. So if you talk to a researcher or read the research literature, you're going to see integrated health be synonymously or univocally used to describe things like collaborative care. And that's because most of the research has been done around depression work in this evidence-based practice of collaborative care. So you'll hear the term integration and collaborative care used interchangeably. If you're talking to somebody from the state or the federal government, you'll hear the term health home used synonymously with integration. And that's because there are federal policies that allow states to draw down money if they define integration using the term health home. Accrediting bodies, NCQA, JCO, CARF, COA, they have their own definitions for integration, and as you know, NCQA uses patient-centered medical home. And then within our provider organizations, many teams develop work plans where they just develop their own term for integration, like patient-centered healthcare home, which really is just a way of thinking about integration that's more local to an organization. So the point here, next slide, is really that you spend the time as a team to figure out where your terms have come from and how you're defining them. Because as you start talking to policymakers, you start talking to providers in your community, as you start talking to patients, as you start talking to staff and coworkers, you really have to know where the terms came from and what you mean. There are some great resources around this. If you want to take a deeper dive, this slide shows an article that you can find on the AHRQ website, or just Google the source. I try to source all my slides so you can go and find out exactly where I'm getting my information. There are places where you can go to really get to the core definitions of the many terms we use in integration. But as I mentioned, the real take-home from what I'm talking about here is spend the time to define your terms so that when you're communicating with each other, everybody's on the same page. Because integration is about systems change, and systems change is very complex. It is a long-term process, and it requires that we all be crystal clear on what we're talking about and why we're doing what we're doing and what it looks like when we actually start doing it. Next slide. So if we're talking about the term integrated health, you know, I like this one. It's about as simple as it gets. It's kind of like messaging on how to lose weight. You just eat better and exercise more, right? Integrated health is bidirectional, meaning you have specialty behavioral health care working in the primary care setting, or you have primary health care introduced or working in the specialty behavioral health care setting. About as simple as you can get, just like losing weight and exercising and eating better, about as difficult as it gets. So it takes a real comprehensive approach and a long-term view. This integrated health work we're talking about takes years. So it is something you're going to be engaged in for a bit as you continue on your journey here. Second slide, next slide. So just briefly, for those of you who don't know, the reason why we're talking about integrated care are a variety of reasons. Some of it comes out of the Affordable Care Act. What's described in the Affordable Care Act for what good health care is, the 10 essential benefits you see in the Affordable Care Act as a requirement for health care. really is a description of integrated health. It's just how good healthcare is done. And the reason why we are talking about integrating healthcare services is because we have so many people with chronic healthcare conditions, 45% of Americans having one or more chronic condition, and because we have such a bifurcated, siloed system of care, and it has driven up costs considerably across the country, as we know. Many of us see different care providers, and those care providers have no idea what each other is doing to support our care. And as healthcare providers ourselves, we're part of that. We are part of the confusion that is healthcare today. The work towards integration is working towards changing that. Next slide. So what does integration look like? Integration is just good healthcare. There will come a day when we don't talk about integration. We talk about good healthcare, and we talk about continuing to provide seamless service. So having superb access where people can come in after hours and get same day, next day access to somebody, a clinician, and maybe access to a prescriber within a week or so. Patient engagement in care. We're not talking about, you know, telling patients what to do and giving them information. We're actually talking about knowing who that person is at a pretty intimate level so that we understand what drives their thinking and drives their behavior so we can activate that person. I'll talk more about that when we get to the workforce section. Clinical information systems, back up one side. Clinical information systems, we all have a love-hate relationship, mostly hate relationships with our EMRs, but they are getting better, and they are allowing us to see things we've never been able to see in our workflows and in our patient outcomes. So leveraging that, we're seeing as being really critical to doing good integrated care. Care coordination, which we'll talk a lot about, is at the core of being able to do integration when we're working across provider networks. Team-based care, which we're going to talk a lot about. Patient feedback, and then publicly available information. So learning from patients, looking at satisfaction as a way to get people to come back to care and to execute on the treatment plan that they've committed to, and then benchmarking ourselves as providers against other providers. We are seeing more and more in the Medicare space this drive towards having providers share information about how good they are at providing health care. This is coming to Medicaid very quickly. So you're going to see yourself benchmarked against other providers in your community, and you've got to be able to show you've got the numbers that reflect you're providing good health care. Next slide. So this 6 levels of integration, you guys have talked about the standard framework. I think the thing I've learned the most over the good 10 years or so I've been working in the integration space is that we do need to move from level 1. Level 1 on the left-hand side here is siloed care. It's bad care. It's people not talking to each other. It's patients having to do their own care coordination and educate providers. Level 6 on the other end, for many organizations, is completely unreasonable. It is something you can shoot for. It is something you can do. You have one organization, one treatment plan, one board, one CEO, and you provide all services. So you're providing physical health and primary care services in the same space on the same team as you're providing behavioral health services. The sweet spot for where organizations, the very least they should be shooting for to do, the very foundation work that has to be done, is the level 2 work. This is robust care coordination. So sharing information back and forth and moving towards that level 2, that level 3 and 4. If you can share staff, if you can share facility space, that is wonderful. It is no guarantee that you're doing a good job of care coordination. So the care coordination piece is really, really critical when you're starting off with integration. And the more you focus on how do we share information between providers, between clinicians, with loved ones of the patients we serve, with the patients we serve, the better able you're going to be, the better able you'll be able to share the progress you're making with patients, but also you'll be better able to develop those partnerships that really lead to level 3, 4, 5 as you move down the integration continuum. that sharing of data, that basic level 2 care coordination piece is really the foundation. So a lot of the focus we see in organizations that do this integration well is around how can we get information shared? How can we start to standardize how we do our services and share the data that we're generating on our teams and between teams across providers. Next slide. So let's look quickly at results here as it relates to what we're seeing in the field around integration. Next slide. If you look at the products of integration or outcomes, research-based outcomes associated with organizations that have moved down that continuum from level 1 to down towards level 6, we see that for people with severe mental illnesses that were engaged in a PBHCI or a primary behavioral health care integration at the clinic level, there were data, and this is a 2013 study. There's going to be a study coming out in psych services, so be looking for it. It's going to be out in the next 2 to 3 months that builds on this study they did in 2013, and the results are good. This study in 2013 showed that if you do this integration work where you really have primary care and behavioral health providers working closely together with each other, you will see reductions in metabolic syndrome and severe physical health conditions, including hypertension, dyslipidemia, diabetes, and cardiovascular disease. So metabolic syndrome is that coming together of these different diseases into a syndrome that kills people. And just by good care coordination and getting staff to talk to each other and getting staff to share information about what they're doing with people on the behavioral health and primary care sides and implementing wellness programming, there were significant improvements in people's physical health. So this is worth doing. Next slide. There's been a lot of work done for youth, and we're now starting to see it come out in the literature, which is really nice. If you look at this 2015 study, the integration of services for kids has shown that you will see improvements in youth outcomes. And a lot of those improvements have to do with prevention work, so making sure kids are getting the prevention work done, and even improvements around substance use, which I know is a big issue in Montana. The practice-based interventions that seems to work well for kids is the same one that works well for adults. So these evidence-based practices around the 5 A's, ask, advise, assess, assist, arrange, these interventions, which aren't new to many of us, when put into an integrated space, having primary care and behavioral health do it together, really produce nice outcomes. So some of the work we already do, we just need to continue to be doing it in a more coordinated fashion with our primary care partners. Next slide. If you look at cost data, there are significant savings that come with integration. That study I mentioned that's going to be coming out in psych services is a study that was done in community mental health centers, and it does show a significant cost savings when organizations integrate. This slide is from Missouri, where they did some really cool work. They divided their health homes into 2 components. One is primary care health homes. So these were primary care providers that brought behavioral health in, and then they had community mental health healthcare homes. These were providers that were community mental health care providers that brought primary care in. And if you look at the data closely on this slide, you'll see the community mental health centers had better outcomes, just a little better outcomes than the primary care centers, but they both had really great outcomes when it came to reducing hospitalizations for patients. Next slide. When you look at the overall cost that had to do with reducing ED admissions, reducing hospitalizations, reducing rehospitalizations, the cost savings were considerable in Missouri, and we found the same trends in other states that have implemented integration in the form of health homes. Remember, I'm using the term health home here because it's a policy term describing integration. And Missouri, just like Montana, is a state that got federal funding through a Medicaid waiver to do this health home work. Next slide. Do people like it? People do like it. And are people getting better? Yeah, they're getting better. If you need any data to show integration works, the best place to look is around the collaborative care model. Most of the work being done in depression in this collaborative care model. And there are now over 30 randomized controlled trials to show that this integration works. Next slide. People like it too. And this is an older study, but we've got lots of evidence from the dozens of clinics we work with around the country. When we interview consumers and when we interview staff, what we find is patients really like this idea that they can get one-stop shopping. And if they can't get all their services at the same site, they at least like the idea that their clinicians are all educated about their whole health, not just their mental illness or just their diabetes. They really feel as though the healthcare system understands them better, which is exactly what we're shooting for, because if patients feel as though a clinician understands them better, they're better able to engage and ultimately change their health behavior. Next slide. So let's dive deep into these integration components. These are some of the things, and not all, that you as a provider are going to really need to understand and grapple with in your work plans. Two things that we're not going to take a deep dive here on, which we will in future webinars, are around financing and data. But we are going to take a bit of a dive here around care coordination, confidentiality, developing care pathways, team-based approaches, and then the factors that influence organizational change to adopt these integrated health models. Next slide. So care coordination is one of those terms that people, on the surface say, yeah, I get what that is, but when you have to put it into action, it gets a little confusing. So it's important to remember that care coordination is just one component of care management. Care management is owning the patient, owning the patient's progress as a healthcare provider, owning that you're engaging and activating that patient, owning that you're sharing data amongst providers, owning that you understand how to bill for that person and make sure that both you're getting paid and that that person's got the healthcare coverage they need. So care management is really owning all the health of the patients you serve. Care coordination is that really important piece that is the deliberate sharing of information between two or more participants in that patient's care and with the patient themselves. So the care coordination piece is really making sure that you understand what you're doing with the person and that everyone else that works with that person understands what you're doing and that you understand what they're doing. Next slide. This is definitely easier said than done. So you really have to take into consideration the different perspectives of the people who are working with these patients. So you have to understand the patient themselves, their family member, and their perspective on care coordination being, how easy is it for me to get into care and to use care? Do I have to wait for appointments? Am I confused after I meet my provider and hear what they have to say? Do I understand how to change my health behavior in the context of social determinants of health that might be working against me from changing my health behavior? Maybe I want to stop smoking or stop drinking, but everybody around me smokes and drinks. Am I getting the support I need from all the providers in my healthcare team to tackle that difficult issue? Healthcare providers have to be able to receive and share information in a meaningful way between themselves, both within the organization and outside of the organization, in order to effectively prevent and treat illness. The policymakers, those systems representatives and payers, need to know that what you are doing as a provider is effective and efficient, that it's within cost and producing good quality outcomes. The only way to do that is to coordinate the sharing of data related to the impact of your service provision. So this care coordination piece is really, really critical. That's why when I mentioned it earlier that 6 levels of integration, that level 2, 3 are really critical because that's when you're developing this capacity to coordinate care really, really well. Next slide. When we talk about care coordination, one of the things we've been hearing, I've been hearing more about this, I don't know about you, Joan, as I'm doing site visits, and I don't know why it's coming up now more than it did probably a couple of years ago, but this issue of confidentiality is really important, so I'm going to spend a little bit of time on it. And I'm not going to take as deep a dive as we could. I mean, we could do a whole webinar on each one of these topics. But I want to touch on it because I've been hearing from providers that, oh, we'd love to, do more care coordination, but we're a mental health provider, and we have a state mental health code that really says we can't just go off and share lots of information with primary care. So I want to be clear that the Affordable Care Act, HIPAA, and some of the things we're going to talk about here really do want you to share this information, and you really can do it legally if you spend the time to understand confidentiality. So for many of us, we remember back to 96, I think it was, when the Health Insurance Portability and Accountability Act, yeah, there it is, 1996, came into existence. We had lots of training on that. Remember, we were training our staff all over the place around HIPAA, and we now, in 2016, think, yeah, we understand confidentiality. We really need to revisit it when we're talking about integration. You need to revisit your confidentiality policies and procedures, because all of our staff have kind of old ways of thinking about this, and we need to resurrect that thinking towards modern thinking, which includes robust care coordination. So when we're thinking about, looking at confidentiality, we have to take into consideration HIPAA. We have to take into consideration 42 CFR, which is our substance abuse requirements. We have to take into consideration state mental health and substance abuse disorder treatment legislation. So each state typically has a mental health substance abuse codes which require organizations to have more protections for behavioral health data. Now when I say behavioral health, I define that term as mental health and substance abuse. So these behavioral health or mental health substance abuse confidentiality laws that exist at the state level have to be really well understood by providers and have to be understood in the context of HIPAA. So when we talk about doing integration, there are some administrative elements that we need to understand and put into place when we're starting to collaborate with providers in our healthcare market space. So if we're a behavioral health care provider and we want to start sharing data with a primary care provider or even a specialty care provider like a podiatrist, we need to go back and as an organization look at what are our confidentiality policies and what part of our policies are getting in the way of us being able to share data. There's 2 reasons why our confidentiality policies might get in the way. They might get in the way because legally we just can't share data based on mental health code law or 42 CFR or HIPAA, or as we find when many organizations take a deep dive into their confidentiality policies, there are some urban myths in our policies that just aren't true, that we've adopted because we want to be very respectful of our clients and not overly, quote, overly share data. So when you look at HIPAA, when you look at 42 CFR, there are some things in there that can be very helpful in redefining how you do confidentiality or policies and procedures around that. And one of them is this business associates agreement and qualified service organization agreements. So when you look at organizations that have done integrated health well, they've really spent the time with their attorneys and spent the time with their integrated health partners to look at what data can we share, what data can't we share, and then how do we integrate our consent forms to be able to share as much data as we can. Many states have attorney generals, Michigan, Kentucky, that have allowed mental health providers to integrate their substance abuse and mental health and primary care consent forms into one form that a patient signs, typically once a year, that allows you to share data. Now, some states require you to get a separate consent for every bit of data you share between providers, and that's just the way it is, so you've got to design your consent forms around that. But understanding that fact and understanding whether you can combine consents and understanding how often you have to get a patient consent from somebody to share data is really important. So revisiting that is really important. Next slide. These business associates agreements are really important, and there's a couple components that the Health Information Portability Accountability Act gives us to help be able to do this better. And it's called the Organized Healthcare Delivery System. It's a definition within HIPAA, and it says that if you want to clinically integrate care settings and want to share information, here's how you have to do it. Again, with the caveat that sometimes state mental health code or law, you can, make this a little more complicated than I'm presenting it here. But essentially, both providers have to say, we're going to hold each other responsible for the sharing of information, and we are going to say we have a joint agreement. We're going to draw that up through a business associates agreement, which is a form of a contract, and we are going to participate in at least one of these activities. We're going to do utilization review together, meaning looking at service use and cost. We're going to do a quality improvement project, once a year. We're either going to do that or we're going to do a quality assessment improvement activities where we're going to start to look at how we share information between ourselves and our payers, and we're going to develop policies and protocols that make that sharing of information more robust and clear. We're going to share payments, so we're going to share fiscal risk to some degree. And then and/or we're going to be participating in a group health plan or a group health insurance issuer or health maintenance organization. So this gets into those accountable care organizations we see popping up around the country. If you're going to become an accountable care organization, that it meets the criteria for being able to develop this organized healthcare delivery system. So next slide. When you're thinking about how to best do care coordination, it really takes you to this notion of an organized healthcare delivery system and what it means for your organization to revisit its consenting process and its confidentiality policies and procedures. At the very least, if you're going to work with a primary care provider, whether they're in your clinic or they're across town and you're going to do really good care coordination, you have to have the CEOs declaring that you guys are going to work together with a letter clearly stating your intentions and what it looks like. You have to show that you're doing this QI or some sort of utilization shared activity. You have to talk about the nature of each other's privacy statements, so being clear about what your confidentiality policy and procedure is and what their confidentiality policy and procedure is and how the two interact with each other. You have to have this agreement reviewed by your attorneys and really reviewed from the perspective of 42 CFR if you're talking about substance abuse data sharing and the mental health code of your state. This joint agreement really has to give staff clarity on how they share data in the care pathways between providers so that they're not confused. It's very difficult to unsaddle or change the mental model staff have around confidentiality. I was talking to a provider last week that has a very good confidentiality agreement with their system of care providers, and they still have staff who, when the primary care provider calls and says, did our patient make the psychiatry appointment, the providers, their behavioral health providers are saying, we can't tell you that because of confidentiality, which just isn't true. So as we move forward, we really need to make sure our staff understand exactly our new view of confidentiality as we do these business associates agreements between primary care and behavioral health. Next slide. And again, stop me as I'm going, Stephanie or Joan, if you see any questions popping up. It looks like people are paying attention, so if you guys have questions, just pipe them up. So now I'm going to talk about care pathways and what that all means when you're designing your integrated programs. These are the mechanisms through which your staff are going to actually be able to do this integrated care work. And as always, we're looking to develop integration that allows our staff to serve the right people in the right order, with the right procedure, at the right time, producing the right outcomes, always with the patient's perspective of care in mind, so that they find the experience easy and they find the experience useful. Next slide. And just keep clicking it and it'll fill in the whole, there we go. So when we look at, one more, when we look at effective care, there are a lot of things that our staff have to deal with every day to provide really good, effective care, right? They've got the patient's goals and strengths, you know, the patient's perception of what they should be doing to improve their health. To the left, you've got community resources or lack thereof, if that's the case. So social service agencies, all the social determinants of health issues, employment, housing. On the right-hand side, you have clinical circumstances. These have to do with the patient's level of judgment. It has to do with the person's level of motivation. You know, are they pre-contemplative, contemplative, or not? At the bottom, you have here the clinical practice. Now, the clinical practice we're going to talk about as a care pathway. And the clinical practice has to be standardized so it can be replicated and measured, right? It has to be based in some evidence to show that if our staff engage in this behavior, it'll produce these outcomes, because that's effective care. And that clinical practice has to exist in the context of these other things: community resources, clinical circumstances, and patient goals and strengths. Next slide. So as we've worked with organizations, one of the things we've come to learn is that the organizations that do this well, that do not only integration well, but good clinical care well, have designed care pathways. And care pathways really have 3 parts to them. So if we take an example like, let's just pick diabetes care. Each organization has to say, what am I going to do about diabetes now? I'm a mental health provider. What do I know about diabetes? Not much. So what do I need to know? So organizations have to take each one of these clinical conditions, the big killers, diabetes, cardiovascular disease, chronic obstructive pulmonary disease, obesity, really have to look at what is my care pathway as it relates to something like diabetes. And then they have to develop the clinical practice in the staff workflow that explains exactly what you do about diabetes. So front desk staff person, this is what you do when someone comes in and screens positive for diabetes. Peer staff person, therapist, psychiatrist, every person in the organization has to understand the practice you've adopted for treating diabetes. So with diabetes, we've got an evidence-based practice for it. There is clear protocols on how to treat diabetes. The behavioral health provider organization has to understand their role in that care pathway. For some of our practices, we don't have a really robust evidence-based practice. Maybe we just have a promising or a best practice, which means it doesn't have randomized control trials. We don't have really clear guidance exactly on how to do it yet. And we see this for wellness programming. Although we've got some evidence-based practices emerging, I want everybody to keep in their eye out, because Joan and I will be sharing some new research coming out on wellness programs for people with serious and persistent mental illness. But even something around, you know, whole health wellness. How do you help people engage in physical health behavior change around smoking, weight loss, things like this? There are promising and best practices out there that you can pull from and turn into protocols within your organization. So the first step in designing that clinical pathway is to really be clear on what is the clinical practice we're doing in relation to this health condition. How do we screen for it? How do we assess it once we've screened positive for it? And then how do we treat it? The other part of the care pathway that intersects with this is the person's treatment plan, right? It's their understanding and their commitment to changing the fact they have diabetes if it's in an early state, so preventing the diabetes if they're on the pathway to it, or treating the diabetes if they have it. So we have clinical practices we can give to people, but unless they understand them and agree to the health behavior change through their treatment plan, they're not going to get better, right? And then the third part of the clinical pathway is the administrative workflow. So this is what our staff does every day in the context of the person's treatment plan and in the context of delivering clinical care that speaks to how they bill for things, how they chart or put the data in their record, how they do team huddles, how they do care coordination or communication with other providers within your healthcare network. And this is a really critical part because it expresses and explains exactly what people should do when they come to work every day. And unfortunately, many of us have clinicians and front desk staff who come to work every day and they do something different every day as it relates to the administrative workflow. Next slide. Whenever you have variation within the workflow, you've got waste. So really understanding your clinical practices is important. And we have examples of disease clinical practice workflows that we can share with you for many of the health conditions we've talked about. All of your clinical practices have to have treat-to-target metrics associated with them. So if you're going to be treating diabetes, you have to know what well-controlled diabetes looks like in the form of lab values, right? And your staff have to know those, and they have to constantly be striving to get those lab values within target. The data has to be captured in structured fields within your electronic health records to be able to do that, and for you to be able to report it between providers and use those dashboards during your huddles with teams. One of the things that really has to be part of your clinical practice delivery is concurrent and collaborative documentation. This is really a requirement of organizations today, not only because it produces efficiency within the workflow, but it prevents staff burnout. If your staff are charting after they see people, it means they're doing too much work. Next slide. The consumer's treatment plan really has to be one that's designed around people's stage of change, right? It has to speak to where the person is and their ability to understand their illness and they're willing to do something about it. So people can be actively engaged in dealing with their diabetes and working for behavior changes with regard to their diabetes, but really not wanting to talk about not smoking, right? They want to keep smoking. So the treatment plan really has to express that in meaningful terms. And we are seeing that the requirement in the field is emerging that all treatment plans or person-centered plans, whatever you want to call them, have to have quarterly treat-to-target metric assessment, meaning are people getting better, and looking at that on a quarterly basis. The annual review of the treatment plan isn't good enough. It's got to be quarterly reviews of the goals and the treatment targets to see if people are achieving them. The other big part about this treatment plan as part of the care pathway is that you got to be able to share it, right? So at the very least, you need to be able to fax it to primary care providers. Some people are using secure email. Some people are actually walking it over, if that's a possibility, either by having clinicians attend primary care appointments, or if you're in or near the same building, they'd literally walk it over. The highest performing organizations obviously are using CCDs or continuing care document electronic transfer either to a health information exchange or to having electronic health records linked. But we see fewer organizations being able to do that right now, but that's improving. Next slide. The administrative workflow piece is really critical, and again, this is that piece where staff are billing in the same way, collecting data in the same way, teaming in the same way, or doing huddles in the same way. It's that repetitive, standardized protocols around what people do when they come to work every day. The more you can standardize your workflow administrative processes, the less time staff have to think about it, and they can spend more time doing the treatment plan and the consumer engagement that's really required for people to change their health behavior. So the only way to get people to change their behavior in the workflow is to have clear policies and protocols and to have really good one-on-one supervision where supervisors can reinforce staff behavior. Yes, we are doing collaborative documentation, and yes, let me help you do it because I see through the data I'm looking at that you're not completing all your notes within 24 hours. That kind of staff supervision piece is important. And then the huddle component, making sure teams are talking to each other in the workflow. Next slide. As I mentioned, if you don't have your care pathways really well defined and executed, you have waste, because anytime you have one person treating diabetes differently than another, you're going to have waste because one person's going to do it better than another. So standardizing all of your care pathways is really, really critical. Next slide. The reason for this, is really because what gets measured gets done, what gets measured gets improved, what gets measured gets paid for. So now more than ever, we got to be doing this measurement piece. Next slide. Talk a bit now about team-based care and what your staff need to know when it comes to integration. Next slide. And if you recognize that A-team slide, you're as old as I am. Many times we talk about teams as being multidisciplinary or transdisciplinary. Sometimes you see that term. Transdisciplinary is when everybody can do the same thing. It's working on an ambulance, everybody can drive it, everybody can treat. We don't have that with our teams that are integrated. Multidisciplinary is when you have a hierarchical, you've got the doctor makes all the calls and everybody below the doctor does what they're told within their workflows. That's not bad, but what we're really shooting for is this interdisciplinary team where everybody is interdependent on each other within their scope of work. Scope of practices remain the same. We don't want everybody prescribing medications. Only people that can prescribe medication are prescribing medication. Next slide. This interdisciplinary team, again, is a term worth understanding and defining for your organization so that you can work towards getting your teams to operate like that. Next slide. Teams that work really well have this thing called adaptive reserve. And if you worked on a team really well or on a really good team, you've seen this adaptive reserve emerge. Adaptive reserve is the ability for an interdisciplinary team to overcome any obstacle put in its way. And many times we see organizations not using this capacity well. And the best way to use adaptive reserve with your organizations, next slide, is to have them define their care pathways, have them decide how their workflows are going to look, and have senior management approve it. Don't micromanage your teams. Have your teams decide what a huddle should look like. Have your teams decide what your care coordination should look like within the parameters of confidentiality policies and procedures. This team-based care approach is really an emerging evidence-based practice, and there's lots of research around it, and NCQA is now requiring it as part of their accreditation standard. Next slide. Do we have any questions coming in, by the way?
Not yet.
All right. Keep those. If I'm confusing people or talking too quickly, let me know, guys. When we look at the components of an effective interdisciplinary team, there's lots of good resources out there for you guys. Good teams define their team goals well. They have metrics that they all rally around and benchmark against. Everybody has clear expectations of their scope of practice and scope of work. There's a flexible decision-making process where everybody feels as though they have a say in the patient's care and they have a say in how the workflow is designed and executed. There's the ability for open communication, so there's trust, and there's dashboards and things that allow people to see data and see how they're doing in their workflow, in their clinical pathways. And the team has the ability to recognize when it's not doing well and treat itself. If there's frustration or anger, it gets addressed. That's good supervision. That's good team-based care. Next slide. When it comes to what your staff need to know, moving forward, there's a lot out there that's emerging around what good integrated health staff competencies are. And this is just one example. There's a more recent paper that just came out from Sandy Blount, which I really like too, which we can share. But staff have to really develop many new capacities. They have to learn how to do care coordination and be more interpersonal in their communication about what they're doing with clients. This team-based care approach, really important. This systems-oriented practice, so thinking about not only my team, but my meta team, which includes the primary care team across town. People have to know how their behaviors in their clinic affect other clinic teams. And informatics, I'll just call attention to that. That's the ability to use data to inform care. That gets that whole population health management component. Next slide. We've also seen a resurgence of this notion of knowing the difference between simply engaging a patient and activating one. There's a big difference between just sitting down with someone and saying, yeah, you got diabetes, here's what you need to do about it. That's just attending an appointment, right? Activating someone is having them be able to actually leave the appointment with an aha experience that drives them to want to change their behavior. Very different things. And this activation piece really has to do with good goal writing and motivational interviewing. Next slide. This is a slide that we have from the Whole Health Action Management Wellness model that I talked about that we're going to have some research coming out on. And it's just one of the ways to think about writing a good goal. So many of our clinicians really need to revisit, how do I write a good goal with my clients? Not only because we're going to be held to the standard of measuring goals every 12 or every quarter and not every 12 months, but also because we really need to move towards activation and not just patient engagement. So we've got lots of tools on this if you want to talk more about how to do that. Next slide. I'm going to wrap up now with talking about what does it take to actually implement systems change. So we've talked about a lot of the components of integration. We could have done a presentation on any one of these slides probably. But you know, if you're a supervisor, if you're a staff person, if you're a CEO, where do you begin? One of the nice things about integration, which is also maybe one of the hard things, is that it's a systems level change. So whatever you decide to do as your first attempt at doing integration, you have to take into consideration it's going to touch all aspects of what you do. So it's going to touch staffing, there's staff training that's needed. It's going to touch how you even design your building. How's the waiting room set up? How are people put in rooms? Where does staff do their work? It's going to obviously affect your partnerships and contracting, because you're going to have to start contracting more with outside providers. Financing, a lot of stuff isn't paid for, which is an expectation in integrated health right now. So you're expected to do a lot of stuff, but it's not fully paid for yet. So what do you do about that? Clinical practices, we've mentioned clinical pathways, developing those. Health information technology is going to have to change. Your record's going to have to change. Quality assurance and marketing around what you do as an organization and how do you engage clients is going to have to change. Next slide. So that speaks to really needing to be crystal clear on what your vision is as an organization. Do you want to bring primary care on site or not? Do you want to just do really good, robust care coordination and be a specialty behavioral health care provider? It's up to you. It all depends on your organization's vision, your business strategy. What's your organizational capacity right now to do this? You don't want to overshoot. You don't want to undershoot. If you have a lot of innovation going on in your organization, you might want to hold certain things off on your implementation of integration and just do some of the basic stuff now, knowing this is going to take years. Your funding design, you really need to know what your financial house looks like. It's not okay anymore to use kind of block-based funding. We need case rates. We need to know exactly what it costs to serve each person you serve, which is a heavy lift for a lot of organizations. Your health information technology structure is going to have to be tweaked and looked at. Your provider network needs to be better understood and expanded oftentimes. And whether you're a state, you know, you're talking about the state level or urban or rural, There's different things you can do based on where you are looking at doing integration. So there's work that the state has to do, the Medicaid office, and if you're a rural or urban provider, we often see there's different ways to roll integration out based on, what kind of organization you are and where you're located. We often see rural organizations have a little bit easier time, frankly, in doing this care coordination and provider engagement, whereas in urban areas there's lots of competition and providers are less likely to talk to each other. So those things have to be taken into consideration as you're developing your strategy for integrating services. Next slide. Interesting, when you look at places that have implemented integration, it's easier to do the nuts and bolts stuff, or what's described here as discrete structural changes, than it is to get people to behave and think differently. So if you look at what people have done on integration, getting people to change their job description is easier than to actually show that they've changed that behavior. And if you think about it, that's not very surprising. So putting same-day scheduling in, or e-prescribing, or tweaking your electronic health record, as difficult as that is, that's easier than getting a team to be interdisciplinary, or getting staff to use data to inform care, or getting staff to change their clinical pathway designs and how they deliver care. So just something to keep in mind. Next slide. The successful organizations have really done this when they put together their integration work plan, their organizational approach. They're really clear on their vision, their business model, and what they want to do and what they don't want to do. Are you going to have primary care on site or not? Getting that vision clear. Next, back one up, please. Getting that really clear, and then being able to share that with providers. Using a good change management technology, so picking one that's out there, whether it's Cotter or Patrick Lancioni's, having a really good communication plan within your organization about what you guys are doing, and then having a really good work plan, which we're going to work more with you guys on. Next slide. Let's do a brief poll. We've got about 4 or 5 minutes left. I want to see where you guys are, given everything I've said so far. Where would you rate yourself on doing all of this? Are you just starting out? This is that level A where you're just researching, you're listening to people like me, learning about integration, or are you already talking with providers about integrating and doing that, business associates agreement? Or are you just kind of looking at data and how you're going to share it? Where do you think you are? And Stephanie, is it clear how to type it in?
Yeah, they're filling it out right now. So I'll just leave it open for a couple more seconds.
All right, so it looks like most of you are in discussions, which is cool. The data sharing piece, not so much. So that's probably something at the Montana state level we really need to be looking at. How do we help you guys do that better? Great. Any questions that have come through or comments?
I haven't seen any questions yet, Jeff. But so can I say a couple things?
Yes, you may.
Okay. So first of all, Jeff, thank you very much for an incredibly comprehensive and informative set of information. As I said at the beginning, I always learn from you when you present, and the way you connect the dots, I think, is particularly important. For those of you who are out there listening, a couple things in terms of follow-up. Obviously, most of you a lot of you, I should say, are talking to me on a fairly regular basis, so happy to follow up with questions in that format. As you all know, because you've seen the schedule, we have other webinars coming up, and Jeff will be joining us again in several months. Lots of topics yet to come, and so please feel free to email either me or Stephanie with things you wish we would talk about or things from this webinar you wish we could dive into deeper on a subsequent webinar. So just wanted to tell you, if you're like me, you need to process all the things Jeff said today. And if questions emerge, then please let me know. I'll be seeing some of you next week, just at least a few of you. Final thing I want to say, Stephanie, is I think there's the recording will be posted, correct?
Yes, there will be.
So those of you who
And
are on the webinar will, yeah, okay, go ahead.
And everyone will get the recording and the slides. A question came in about that. So, yep.
Great. So you'll be able to review it. If there was enough that you want to go back over it, you'll have an opportunity to do that.
And
so
if
that
people
does
want
take
examples,
just
let
ahead.
us know, because I've got examples for just about everything I talked about. We've got policies, procedures, checklists, all sorts of things to make this more practical. So just let us know.
Yeah. So that takes us right up to the top of the hour. So Jeff, again, I want to thank you for taking time. I know you, like all of us, have a lot going on, and I know you spent a lot of time really thinking through how you wanted to present this material today. So appreciate that. I hope for all of you in Montana you have a wonderful weekend and get some rest this weekend and have fun. So thanks a lot and take care. Bye-bye.
Thanks, everyone. And there's a short survey that will pop up when you close the browser, so if you could fill that out, that would be great. Have a good weekend.